Welcome everybody. We are here today to interview Dr. Ronald Weinstein. He's the director of a national award-winning University of Arizona telemedicine program. He's got quite the CV, so I'm going to keep it short. And he has, for example, over 500 professional publications. He has been the president of 5 professional societies, one of them the Telemedicine Society, and he has received numerous awards. So we're going to start with a few questions and have a little bit of a conversation, but I'm also happy to say that we will have a few demonstrations afterwards. First question. You have been in telemedicine for a long time?
50 years.
From the start?
Yep, well, from the very first telemedicine practice.
What would you say made the biggest impact on the field of medicine?
Well, interestingly, telemedicine was born mature because the technology came out of the space program. And so the initial demonstrations, which were at the linking the Massachusetts General Hospital to the Logan International Airport, had as its main purpose eliminating the need for a doctor to go out to the airport to see patients, very modest. And that program actually became an international model. And by the mid-70s, there were over 100 programs around the world. And then telemedicine went black. 98% of programs disappeared. And that because we didn't have the infrastructure, we didn't have MIS, we didn't have electronic health records, we didn't have reimbursement possibilities. And so even though the technology had been very successful, it basically disappeared. And then it began reappearing in the 1990s for a very wide variety of reasons. And really have to think about it in terms of specific applications. But in recent years, the growth has been exponential, and we anticipate there'll probably be 30 or 40 million cases this year across the country. United Healthcare alone has 20 million people with their health policies who have a telemedicine benefit. So it's in that up. So we have lived literally the S-curve of innovation from day number one.
So what would you say is the most common use of telemedicine?
Well,
is it like a video interaction, or is it
the most common use would be teleradiology.
Teleradiology.
And teleradiology was invented at the University of Arizona in 1973. And it was the first demonstration of digital subtraction vascular angiography, and it was done in our Department of Radiology with optical sciences and engineering, and that became an entire industry, digital imaging. And also teleradiology was started in the same department at the University of Arizona. But that's been a growth industry, and today 85% of hospitals, so in the United States we have 5,500 hospitals, and 85% of them are using teleradiology.
And the evaluations of the images, are they mostly done in the United States, or is there outsourcing to outside
Well,
of the
people
States?
talk about outsourcing. It really doesn't exist.
It doesn't?
There's one guy in Australia who has an American license who does it from home, and then there's one person in Israel who does it. But that doesn't really happen to an extent that would be of any significance. And will it change in the future? Probably not. But today, any medical student coming into a radiology program, training program, or into a radiology fellowship wants to know whether they can do radiology because it really affects whether they're going to get jobs coming out. So it's really become standard of care.
Yes. Is it also part of the education of the general medical education to how to deal with technology and telemedicine?
That's a great question. You know, we have this big building that's going up outside, which you probably just walked by. And that is very equipped. For example, it has a huge simulation facility, and they're going to use telemedicine as one of the things that they're simulating, or we're going to simulate. We'll have a very state-of-the-art education facility that I'll be running, which duplicates one we've had up running for years in Phoenix, called the T-Health Institute. And today, 2 or 3 years ago, across the United States, 41% of schools had telemedicine in their curriculum, and last year it was 77%. So we certainly intend to have a leadership role in including it, and particularly for interprofessional education, because we can draw the various professions together.
That's actually a good lead into my next question. I was wondering, there are different stakeholders in medicine. You have the patients, you have the clinicians, the caregivers. For each of these groups, what would be the most exciting development in telemedicine? I'm assuming it's different for the different groups.
Well, for many physicians, the best development would be for it to go away. You know.
Together with electronic health records?
So the caretakers. It depends on the specialty. So we talk about telemedicine as if it's tele-everything. It's not tele-everything. It's certain niches where telemedicine works well, has been validated, and makes a difference. So a very good example would be telestroke. So today, we have the golden hour, and if we can diagnose a stroke in a patient, we can infuse a drug called TPA and abort the stroke and prevent a stroke. And of course, that's a catastrophic disease to have. And but it has to be within that 1 to 3 hours. So today we would have rural patients being diagnosed. Their CT scans would be diagnosed here. But the drug would be with the patient out there in the refrigerator, and they could avert the stroke. And so that's becoming a standard of care. And now that's migrating into urban environments. So that's a biggie. Dermatology is an application that works well. Dermatologists don't want to do that. They want to do cosmetic dermatology. So, you know, let's face it. And they want to be, and I'm not, you know, I'm just describing how practice really is in the trenches. And you know, they're concerned about continuity of care. So if the patient needs a biopsy, they want to do the biopsy, and they lose that opportunity if the patient's somewhere else, and they got better things to do. So there's almost no teledermatology that takes place in the United States, even though we know that for an internist looking at skin lesions, say inflammatory skin lesions, the diagnostic accuracy may be 50%. But in the hands of dermatologists, it goes up to 90%. I mean, those are just rough approximations for the sake of discussion, but not too far off the mark. But we don't have a workforce that really is interested in doing it. So there has to be that balance. So there are areas, you know, the half a dozen areas that telemedicine is important. And there are a lot of areas where there are either lack of it in terms of interest, or lack of an overriding justification for doing it, or in many cases a reimbursement issue.
So you spoke mostly of applications where you have a clinician in the loop somewhere. So what do you think about some of these apps now that we have, for example, in dermatology, to help people self-diagnose? Do you see that? Do people bring that in? What do you think of the influence of that?
It's interesting. I mean, I think it remains to be seen. I don't think there's certainly some sacrifice in diagnostic accuracy. It can be very, you know, if you get diseases that are high-risk diseases like melanoma, you know, would you really take a chance? And in a setting in diagnosing melanoma, you don't want to give up a single percentage in diagnostic accuracy. It's so important. So there are over 200,000 apps, healthcare apps, and the FDA, as of last year, had approved about 120 of them. So when we talk about the apps, we have to say, is a consumer, what part of the drugstore are you buying it in? Are you buying it where you actually need a prescription? And those would be the ones that are the FDA-approved ones versus ones that are available for the general public. And those are two different worlds. And generally, the ones that have been approved by the FDA have been proven to be efficacious. The FDA has a really important role in looking at applications. And so if we're monitoring irregular heartbeats in patients with atrial fibrillation would be an example, you know, they can be extremely valuable. So again, it depends on the specific clinical situation. And if one is going to generalize, one is going to say, well, if we're talking about FDA-approved apps, that's a category that's relevant to medical practice.
So I would love to see a demonstration, but before we go to the room for the demonstration, I have one question for you.
Yeah.
Usually we're used to seeing people in white coats And so you're wearing a blue coat. Is there a special reason for that?
Well,
I think there is,
for the
right?
videographer's benefit, we got this handsome guy sitting over there with a headset, and obviously extremely, and I'm trying to help him because he doesn't have to worry about white balance, not to mention the fact that I look good in blue.
So this is common, you mentioned earlier, right?
Yeah, around the state of Arizona, the telemedicine rooms are always blue, just like the one next door. But the white balance issue is very significant. We're interested in looking at fine detail, and we're interested in not, of course, not having color distortions and so forth. So and blue lab coats are available, and so we've tried to standardize around blue.
Shall we go put them to the test?
Yeah, let's see.
Let's go.
What we're showing here is a typical unit that we would have, say, in a telemedicine clinic remotely. And this includes several specialty cameras. There's a general camera that we can do close-ups. Angel will show us what her eye looks like using that. And also we can do a look into an ear. So that's a very common application for schools. Does the patient have, does the kid have otitis media? Is it bacterial? Is it viral? We can do that remotely. Do you have to treat with an antibiotic?
And we also have the ENT scope.
We have an ENT scope, yeah. So these are all applications. And what we're going to do is she's going to turn a couple of these cameras on just to give us an idea of what things look like with these cameras. And then we're going to go down to where the physicians would sit and look at them just so you can see what they look like remotely.
So one thing you can see that we're showing on the monitor, this area with the doctor review small. Now you can, when you're here, change this view so you can see the doctor review area and you become small depending on what application you're doing, and
Right.
switches back very easily.
So the patient would be sitting here maybe and
Right.
seeing
With
the
a
doctor on
presenter,
the screen.
with the presenter being
Yes,
here.
and you'll get more of a view of that in the doctor review area.
Right.
You'll get more of an idea of how it works.
Right.
When you go in there, I'll switch a camera
Right.
Yeah.
and
So-
show you some of the
Right,
cameras.
exactly. So we use this as a training facility, and we run 6 training sessions a year, training programs. We do them simultaneously in Phoenix and Tucson, and we also do one in Flagstaff. And we've had thousands of people go through our training programs. And the reason why it's important that we do that, because people want to learn it immediately as the next step in their job. They can't do it once a year.
Yeah.
So that's a reason for doing
So
it.
the students get one-on-one training here?
That as well.
Or more?
It's really people out who are actually healthcare providers who are in the
okay.
training.
Yep.
So it's
We
actually,
have a basic and then a 101.
Yeah,
Which
and
is
maybe
our
before they buy
applications.
equipment themselves. they
right, we
can-
teach them about the
Yeah.
equipment. We have experts on facility design. We have them pick out what color they want to make the walls.
Right, and we do a lot of telegenetics training here. It shows them, they get to use the equipment, and then we do mock patients so they can get used
Right.
to the interaction
Right.
over the
Right,
monitors.
and that's a national program, a big telegenetics program that all basically comes out of our program with a large federal grant. Okay, well, show us one of the cameras,
Okay, do you
Angel.
want to go in the doctor review
No, I'd like
area?
to just let us first see it here,
Okay.
so they'll see what you're holding, and then we'll go down there and we'll see what it looks like at a distance. So which one are you going to show us?
I'm going to show you this one first, so you can see
Ooh.
the skin. This one's a lot closer, a lot more sensitive. But I don't know where the ear thing is, and I don't want to look at my ear. But you can see the skin. And did you tell him, Dr. Weinstein, why we have this blue color?
We did, yeah.
Okay.
Right.
So that's that one.
Let's use the general. Do you know how to use the general
So
exam
let me go
camera?
back here. The camera's down here, I believe.
Yeah.
And you can see this one is more handheld also. This one's older than that one, I
Yeah.
believe.
But we
and
like
so-
it because it makes us look younger.
Oh, the camera must be right here then.
That's right. She doesn't ordinarily do this demonstration. The
Right.
the gal who does it normally
But
is off today.
this is an
Can you
older
show us
model.
what your eye looks like?
You want to show my eyes?
Yes, beautiful idea.
I do have
Come
contact
on.
lenses.
That's all right. Let's see if we can see them.
Just sit here.
Just easier if you kneel in front of it and
Oh my,
There
perfect.
you
You
go.
have to get that close.
don't have to get a little bit back. You can take a picture.
right there.
Okay, now you're actually going to be on the tape.
Oh yeah.
Nice
Can you
hair.
see my contact
Got-
lenses?
No,
Yes,
really?
yes.
You can?
I can see the edge over here.
Oh, okay.
See the round thing? Nice.
Oh, okay.
They fit beautifully. Okay, there she is. Look at the detail.
Yeah.
Now, one of the problems is that we don't ordinarily see people this close. So there would be situations where there would be overdiagnosis.
Yeah.
So the training becomes very important to get acclimated to what it looks like at a different magnification.